Good evening. Thanks for always staying with Lagos Television. The program is Sound Health. I am Olasumbo Modupe. Every 50 seconds, somewhere in the world, a woman dies from breast cancer. More women with no family history now come up with this disease. Today on the program, we are taking a look at how to manage and detect breast cancer early enough. Stay tuned. The conversation begins after this break.
WHO has today issued a medical product alert for 4 contaminated medicines identified in the Gambia that have been potentially linked with acute kidney injuries and 66 deaths among children. 4 medicines are cough and cold syrups produced by Maiden Pharmaceuticals Limited in India. WHO is conducting further investigation with the company and regulatory authorities in India. WHO recommends all countries detect and remove these products from circulation to prevent further harm to patients.
It is still Sound Health on Lagos Television. Joining us via Zoom this evening is Dr. Temitope Olatunji-Agunbiade, consultant radiation and clinical oncologist with the Oncology Department, Lagos State University Teaching Hospital, Ikeja, here in Lagos. Good evening, Dr. Olatunji-Agunbiade, and thanks for always obliging us.
Good evening, madam. How are you doing? Thanks for having me here. It's a great pleasure to be here.
I am fine. So this month is celebrated as the Breast Cancer Awareness Month. I would like you to tell us why breast cancer is still the #1 cancer in the world. Why is this still so?
Breast cancer is actually the #1 cancer in the world with a percentage of 12.5% of all cancers, basically. I think awareness is increasing here and there globally, which is why people are coming forward and we are able to get these figures that we're getting. Basically, that's just it.
Okay, Dr. Olatunji-Agunbiade, what causes cancer? Let's start with that.
Okay, basically, cancer, it's most people, they don't know what it is. They keep asking, what is this cancer? What's the cause? Cancer basically can occur anywhere, and it occurs as a result of disorderly growth or haphazard growth or abnormal growth in layman's language of cells, which make up, which is what makes up every living organism. Every living organism is made up of cells, which are small units that comes together to form mighty organs and all that. So cancers can occur in the cells that everywhere. It can occur in the breast. It can occur in any part of the body that is made up of cells.
All right.
So
you can go ahead with your thoughts.
Okay. So it can occur in any part of the body that is made up of cells. All right. So in layman's language, it's just disorderly growth or abnormal growth. All right. Naturally, God has made it in such a way that there is what we call programmed cell death, apoptosis. When cells grow to a certain level, they are supposed to die off and new cells will regenerate and grow from there. But in a situation where there is cancer, those cells don't die, they just grow and grow and grow on their own, and they are the detriment of the other parts of the body. They take up blood supplies and all that, and even send projections to different distant organs, which is also known as metastasis.
All right. So since we don't know the causes of breast cancer or any other kind of cancer, are there types of breast cancer?
Yes, definitely. There are different types of breast cancers. We still don't know the cause of breast cancers right now. However, there are predisposing factors, there are risk factors that we know that are associated with breast cancers, okay? But before I go into that, let me just quickly tell you about the types that we have. Breast cancer, the breast is is a component. I mean, is made up of glands, of ducts, of fat cells, of blood vessels, of connective tissues. So, and those ones have cells too. So cancer can arise from any of those areas in the breast. So if cancers arise from those areas, the cancers are named according to the location or site where it's springing up from. Like if it's starting from the ducts now, we'll call them the ductal cancers. It may be pre-invasive, which is ductal carcinoma in situ, or if it's starting from the gland, that might be, and I mean, those are the lobules that carries the breast milk and all that. So if it's starting from there, we'll call them the lobular cancers. If it's starting from the connective tissues, I mean, we have those mesenchymal tumors, the sarcomas of the breast. If it's starting from the blood vessels, we call them the angiocarcinomas or angiosarcomas. I mean, basically that's what we call them, depending on where they start from. So let me just quickly go to the risk factors.
Okay.
We don't have any known cause. We don't have any known cause per se. However, there are certain risk factors that are associated. You can, and to better explain them, you can put them under these two groups. We can say they are modifiable and non-modifiable. All right. The non-modifiables, I mean, the number one, I mean, the non-modifiable means in layman language, you don't have any power over it. I mean, it can just occur. Those kind of situations are situations that we see, you know, the one of the major causes is the female sex. We all know that breast cancer is commoner in female. To get it in male, it should be causing like 1 in 1,000. I mean, the risk of getting it. While for women, 3 in 8. You can imagine the great difference. So the female sex is number one risk factor. The fact that you're a female, you can have breast cancer at any time. Nobody is immune. Then the age. We're getting to see cancers before it used to be like, say, from 40 and it peaks in like age 50. Now we are getting to see breast cancers in people that are in females less than 30 years. I mean, I've had cases of seeing breast cancers in patients like 25, 26, 27, 30 years. So other factors that are there, they include the family history, the genetics. You don't have any power over where you're coming from or what your family is, your parents are going to transfer down to you. We're talking about the BRCA1, BRCA2 genes that, you know, that they can pass down the line to their offsprings. Okay, so we are also talking about the breast density. Some people have dense breasts, some people don't have dense breasts. Those people that have dense breasts, I mean, it's not their making. I mean, they found out that their breasts are dense, so they are more prone. They are more. It's one of the non-modifiable risk factors. They are more prone. Then there are certain histories of breast lesions that you don't have any. Some may say, okay, they have benign breast lesions, and over time, by the time they keep recurring and all that, they keep biopsying and all, they can find out that either one or two of them might have undergone differentiation and is now malignant. I mean, those are just the non-modifiable factors. Then the modifiable factors, they are the ones that you have power over, that you can change. And this is what we're really advocating for, that people should just go ahead and work on these factors so that they do not have this disease. I mean, number one and the commonest one is the being overweight and with obesity and all that. They are more prone if they continue maintaining their heavy weight without inactivity and all that. They are more prone to having breast cancers. I mean, excessive alcohol intake and tobacco use. Tobacco, we even advise that they quit tobacco smoking. I am an advocate of no alcohol intake, but some patients will say, doctor, you don't expect us to just cut off completely like that. For those kind of patients, okay, work on it, moderation, take it in moderation. But the best thing is to go off alcohol and cigarette, all right? Sedentary lifestyle is also a major one, where you're always in the office, you're home, you don't move around, you don't do exercise, you don't get to do all those things. So we advocate that patients should just go ahead and lose weight and keep themselves busy. Other factors include nulliparity. For those people that have not given birth before, I know you've heard of the fact that breastfeeding is protective. I mean, it's a protective factor. If you breastfeed very well, there's a lot of reduction in the risk of getting breast cancer. Then use of oral contraceptive. These are hormonal drugs. We kind of advocate and tell patients that if they're going to do contraception, they should do the non-hormonal contraception and use the non-hormonal contraceptive methods that are very useful, So oral contraceptive use, they're exposed to hormones like estrogen, which is a fuel for breast cancer. This is a known fact. It's an open secret. Everybody knows about it. All right. So also environmental factors. So unnecessary exposure to ionizing radiation. All right. So you see, when we are treating our patients with breast cancer, one of the treatment modalities is ionizing radiation. We treat them with radiotherapy. All right. So we tend to protect the area that is not affected. All right. So, and this is the essence of using precision-based treatment, high precision-based treatment. We'll do contouring, such that the areas that only need that radiation is one that is touched. We'll contour, we protect all the organs at risk, such that highest dose of radiation is going to that organ, and no radiation at all, or minimal dose, is going to organs at risk or surrounding structures. I remember in those days when there was this Chernobyl accident. Over time, there was mutagenesis and all that, and people had stochastic non-deterministic effect. Sorry, that's a terminology that I should just explain. So if they receive unnecessary exposure to radiation, over time there may be mutagenesis, carcinogenesis. Years down the line, cancer can come up. So it's also a risk factor. So basically, I think I can just recount: being overweight, obesity, excessive alcohol intake, smoking, smoking risk factor, sedentary lifestyle, not breastfeeding, nulliparity. Nulliparity means you haven't given birth, or those people that have given birth, they will not breastfeed their children. Postmenopausal hormonal therapy. When people attain menopause, the hormone estrogen is doing a lot. Is maintaining the density of the bone, is making women look youthful and all that. So by the time they attain menopause, those beautiful effects are not there. Their bone density there's osteoporosis and all that. Yeah, so some of the doctors prescribe hormone replacement therapy. These are not so good. They predispose to cancer. There's also a terminology called estrogen window. Estrogen window means it means early menses less than 13 years, all right? As in, once attaining menarche, which is starting your menses, less than 13 years, and attaining menopause later than 50, all right? So the estrogen window there is such that the individual is exposed to estrogen expression for a long period of time. You start on time at less than 13, and you still don't attain menopause at age 50. So that patient is exposed, and that kind of increases the risk of developing breast cancer.
All right, Dr. Olatunji-Agunbiade. I know you've talked about the risk factors in men and women. So I would like to know, unlike women, are children and men susceptible to breast cancer?
Yes, I mentioned earlier that we've been seeing cases of cancer in younger patients now. We've been seeing them in younger patients. Men can have it. The risk of having it, the incidence is about 1 in 1,000.
What about in children?
Children can have they can have cancer. They can have cancer. in adolescent, those that have, I mean, not in children that don't have breast too.
Okay.
So in youngsters, I mean, we're beginning to see, particularly in those or in those patients whose family or first degree relative have issue of cancer. So you cannot rule it out.
Okay. All right. Many people now report at the hospital at a very late stage. What are some of the symptoms you've seen that you can let them that people need to look out for?
All right, I mean, the signs are out there. I mean, it's not like it's an internal organ that you will not see. It's just that most patients just prefer not to come early. They come when the disease is really advanced. However, from the onset, they would have been seeing some signs, and some of our patients would have been hoping and praying that those signs or symptoms will disappear. So some of the early signs that they can see, they can feel breast lump. They can feel lumps in the breast, or even change in skin color. They can see change in skin color, or something, or some lesions, the eczematous lesions around the areola and all that. I mean, they like scaling off, or they can even see dimpling of the skin. I've seen a patient that said she just saw dimpling of the skin. I mean, that was the only the symptom that the sign that she saw. And some patients, they can see lump. They may not even see any lump in the breast at all. It may just be in the armpit. Some cases are like, I mean, they can present that way. They see them in the armpit or even in the collarbone, in the collar, I mean, just above the collar here, the supraclavicular region. They can see it there. Then also you can the nipple can retract. It can go in. I mean, just like dimple in, like go back in. They can have nipple retraction. I've mentioned they can have nipple discharge. There can be nipple discharge. It can be brownish to bloody in color. All right. So if they don't see that, any of those, some patients can even present with features of metastasis. It can be that bad. Some patients can present with features of metastasis. Some it can be bone pain. Some it can even be fracture. We call them pathological fracture. They can present with fracture, and we'll start looking for where the problem is, you know. And some it can be breast swelling. Some it can be cough. Some they can present with effusion, and you are wondering what is happening. Or some they'll say, okay, after, you know, normally with the hormones in the female breast, after the menses, I mean, during the period of ovulation, menses, the breast may become engorged, the lobules and all that, they're engorged. But after the menses or after the ovulation period, you notice that the breast is supposed to go back. I mean, the size is supposed to go back to normal. So if it still remains engorged or is different, you should go ahead and look for solution. Get yourself examined. Either get yourself examined or go for screening. Something may be happening down there, right?
So how often should women check their breasts?
Okay, for women less than 40 years, there are certain investigations they can do. For women above 40 years, they do mammograph. For people less than 40 years, they do ultrasound scan, all right? For people less than 20 years, I mean, for everybody individually, you should know your breast, know what feels normal, what is not normal. You should be able to do your breast self-examination by yourself. I mean, do it monthly, know what the breast feels like before your menses or after your menses. If you notice anything, go ahead and just meet an expert and say, this is what you're saying. So for people like 20, just do your breast self-examination, or you go to the doctor and do your breast clinical examination. For people like under 40, ultrasound scan, you can do the ultrasound scan. It will look at the axilla, it will look at the breast. As a matter of fact, the ultrasound scan picks nodes in the armpit better than even the other investigation. So they should get that done. They should do yearly mammo. Yearly mammo can be done. And if you notice anything, I mean, there are different modalities of looking at the breast, all right? Apart from ultrasound scan, apart from mammo, they can do MRI. For some lesions that are really tiny, that sometimes the mammo will not pick, ultrasound scan may not pick, the MRI will pick it up and it will tell you the characteristic, the texture, and what it looks like.
I have been speaking with Dr. Temitope Olatunji-Agunbiade, consultant radiation and clinical oncologist with the Oncology Department, Lagos State University Teaching Hospital, on how to detect breast cancer early enough. It is still Sound Health on Lagos Television. More to come in a moment. Okay, Dr. Olatunji-Agunbiade, let us know more about the treatment options. What should we expect during treatment?
We can just go ahead and do maybe mastectomy or breast conserving surgery. Then after that, you go ahead with chemotherapy and go ahead with radiotherapy. Then, depending on what the tumor biology is, which is what will be the guiding factor, either you're going to add targeted therapy to it or not. So that's on one point. All right. Then if the tumor is more than 2 cm, it's always advisable to just go and give like neoadjuvant chemotherapy first, downstage the tumor, then go after downstaging, then go ahead for surgery depending on the patient's options. We give them the options that they want. Are they looking at either you do mastectomy or whatever it is, or a breast conserving surgery? Some patients will say, why don't you just remove the breast? I mean, in case the thing comes up again later in life, then they can do a mastectomy. Then after the mastectomy, we'll go and do a local control. We'll sterilize the tumor bed such that we don't have those kind of reoccurrence again with radiotherapy. We'll give them radiotherapy. If the patient is hormone receptor positive, we'll commence them on hormone receptor blockers. And if it's not hormone receptor positive, I mean, we'll keep monitoring the patient. If it's a triple negative breast cancer disease, we'll keep monitoring that. But if it's HER2 positive, patients would have been on Herceptin or Perjeta, I mean, the new molecule now, would have been on that. Then we'll continue even after the chemotherapy or while they are taking the radiotherapy. All right. So in a nutshell now, treatment modalities include surgery, chemotherapy, radiopsy with surgery. We'll do either mastectomy with surgery. We'll do either a breast conserving surgery, the wide care excision or whatever it is. So after doing that, the other modalities include radiotherapy. We can do radiotherapy to sterilize the tumor bed after removal of the tumor, or we can use radiotherapy to tackle metastatic disease that is problematic, causing pain. We can use it or in a situation where the breast lesion is bleeding, we can use it to stop bleeding, to stop pain, and also to stop further damage to the bone. We can use that. Then also hormonal therapy. Hormonal therapy, like I said, you must do the tumor biology. If it's hormone receptor positive, we give the hormone receptor blockers. We give tamoxifen in patients that are less than that are still seeing their periods. For patients that are postmenopausal, we give them aromatase inhibitors. We have the anastrozole, we have the exemestane, we have arimidex. I mean, we have quite a number of them. So the newer drugs also, the targeted therapy, I mean, they target the receptors that are on the tumors. If it's HER2 positive, we'll give Herceptin to block those receptors, or we'll give Perjeta. And there are other newer molecules now, TDM1. I mean, there are other drugs that are coming up. Then for hormone receptor blockers, for there are newer drugs now. The CDK4/6 drugs. The drugs in that category include the palbociclib and all that. So quite a number of drugs are coming up now that we are using to tackle breast cancer. For the immune therapy, they kind of have this is their mechanism of action. They kind of increase the body's immune system so that they tackle breast cancer, they tackle the cancers. The body can fight against the cancers. The body sees the cancers as strange agents and tackle them basically. So those are the treatment modalities that we have. All right.
This could be overwhelming. This could be, stressful for patients that have just been diagnosed of cancer. Are there actually support systems to help these people pull through at this trying moment?
Yeah, diagnosis of cancer can really be overwhelming for not just the patients, the relative, even for doctors, because we are not just clinicians. We do a lot of counseling and all that with what we do. Patient can come in for consultation and you can spend about like 30 minutes or thereabouts, even with just one patient. Depending on how, or depending on the psychological, emotional state of that patient. So it's not an easy diagnosis at all. All right. So we try to encourage psychotherapy. All right. We have units that do counseling for these patients, for their relatives, So they kind of there's this stage of denial, we'll take them through it. Oh, God forbid it's not this one and that one. Once they are there, then they begin to accept. Then before they now said, okay, we are coming in for treatment. Because we actually get to see a lot of situations. Some they accept it, some they don't even accept. Some say, oh, God forbid. Meanwhile, you are seeing the disease everywhere. So they need emotional and psychological support. We have health professionals in that field. They also come into play. They help us to counsel this patient. They talk to them. After all this, most of them agree to go on or continue their treatment. We also have quite a number of socioeconomic problems, So we try to involve the relatives. I'm always glad when a patient comes in with their husband or comes in with their sibling or comes in with their children. They are getting the family support, which is quite important for those patients. You get to see the difference in those patients that don't have the family support. You see wives that say, oh, the husband have left them. You can tell that, the margin is just really wild. But when they have the support, the love and the care of the family and all that, you begin to see the difference. Emotionally, they are stable, they accept their treatment, the outcome and all that is actually better, all right? Another major issue that we have, our economic issues. Most of them, they come in, they don't have money. You tell them this is what we're going to do for you. This is your treatment plan, and you begin to crack your head, not just even about the mental issues now, the financial issue. Most of our patients pay out of pocket. Majority of them pay out of pocket, and they cannot afford it. We have to look left and right and look for NGOs that can help them. You can imagine how bad it is, even for doctors. You are cracking, you know what to give your patient, you are cracking your brain, and patient cannot afford it. It's very depressing. But you just have to stay strong for them and try to connect them here and there to people that can help them, the NGOs that can come in to support them. So I think that's just basically it.
Earlier in your response, you said there's always a reoccurrence after treatment. Why do we have this, and what's the way to go if this is the situation?
Okay, if patients present late and you have to downstage that disease, there is a high chance of reoccurrence, all right? Or patient is treated or receives half treatment. I've had cases whereby a patient came in with a stage 3 disease and were able to downstage the breast tumor. We gave chemotherapy, neoadjuvant chemotherapy. The tumor got shrunken, and we referred the patient for surgery. Lo and behold, patient disappears. And by the time patient comes back, she said, okay, that she was scared and all that. By the time she comes back, the tumor that has gone down, that was operable, had become inoperable. So we get to see situations like that. If they come early, we will not be having situations like this. Once you have a lymph node metastasis in the armpit, you have to treat aggressively. It's either you downstage After downstaging, do your surgery, do chemo, downstage with chemo, do your surgery, do radiotherapy, receive optimal treatment. If patient does not receive optimal treatment, there is a high chance of recurrence. A high chance, not even just recurrence, even metastasis. Most of them come back with metastatic diseases. So these are some of the major challenges that we face as health practitioners, and these are situations that we see every day. So if patient can endeavor to come early, go for your screening, do your breast self-examination, catch the disease early, catch it early, do the appropriate treatment, go for appropriate care and support, do the treatment. And once you start the treatment, don't run away, don't do haphazard treatment. If you complete your treatment, God willing, you should be fine. Although there are some aggressive diseases, there are different factors that lead to good treatment outcome. One of them is the late stage of presentation. Then the grade of the disease. We have like 1 to 4 grades, 3 grades. There is grade 1, which is well differentiated, it's not aggressive. There's grade 2, which is poorly differentiated. It's neither here nor there. Grade 3, which is a high grade disease, which is the one that is aggressive. Those ones can metastasize early. Sometimes, if you even catch them early, they treat them, they can still reoccur, they can still metastasize. But unfortunately, in most cases, they do not present early. So then, the patient's preference. What if you catch a disease early? You catch the disease early and you counsel the patient on treatment options. And patient tells you, oh, doctor, I'm not interested. Or you know that a breast that, you are just only able to shrink, it was by God's grace that you're able to shrink the breast to make it operable. And after doing that, patient decides she doesn't want to do surgery. What are you going to do? Those kind of situations can really cause problems. We put them under patient's preference. Then comorbidities too. A patient that is not fit for chemotherapy, what can you do? You cannot give chemotherapy. A patient that is not fit for surgery, what can you do? You cannot. So they all are intertwined. These are the major factors that give us a good treatment outcome.
All right, Dr. Olatunji-Agunbiade, before I let you go now, what should a patient expect during treatment? We read at times where they say they experience hair loss, they experience weight loss. What are the things they should expect during treatment?
Okay, there are different chemotherapy regimens. There are different drugs that we use. Some single agents, some like doublets regimens, all right? And there are different side effects. Some drugs, there are some drugs that are cardiotoxic. So before we put those kind of patients on those kind of drugs, we would have done appropriate screening and all that. Can this patient tolerate this drug? What's the injection? Can this patient take this drug and all that? So before we put a patient on a particular drug, we would have screened and make sure that the patient is fit for this drug. So the common side effects that they see, particularly in anthracyclines and all that, which are this is like the major, like the backbone regimen for breast cancers. Patients, there's something they call alopecia. Patient lose the hair. All right. Before we start, sometimes I tell patients, if you are going to, it's very devastating to lose your hair. Imagine combing your hair after starting chemotherapy and your hair is pulling up. So I just tell those patients, why don't you get scissors and cut your hair by yourself? Maintain a low cut, start pouring water on your head, start getting accustomed to that low haircut look, get beautiful wigs and all that. These are just ways to you encourage them, and also to counter the emotional, the psychological aspect of it. Cut it by yourself. If you cut it, pour water on your head, get wigs. Another major side effect, you can see change in the skin color. I would have prepped the patient and told them that, okay, some of these classes of drugs, when you take them, they may be changing skin colors. It's just for a little while you're on treatment. After your treatment, things will get back to normal. They may experience even So with all this, for babes, I mean, young sassy ones, a patient, get nail polish colors, colorful polish. You can apply them. I mean, you don't have to look sick while you are taking treatment. I mean, once my patient come in, they say, oh, when they're coming, they say they can't afford to be looking down when they come to see their doctor. So when they are coming, you will see them. Sometimes some people will say, are you sure you're? They say, yes, now. They say they are a patient, they are trying to come in. I mean, you don't have to look drab. Get beautiful wigs. You can put your makeups on. I mean, when you lose your hair, it's not the end of life. The hair will grow back. After all your treatment, things will get back to normal. All right. So those are some of the side effects. They may feel nauseated. I mean, there are drugs that we give patients before chemotherapy. These are supposed to help them. They are anti-emetic, anti-vomiting. They are supposed to, or even sometimes antihistamine. I mean, they are supposed to suppress the side effect, reduce the nausea, reduce the vomiting. So usually I like to give it for at least 5 days, even after chemotherapy. Yes, because the first 5 days is actually the acute period where they may feel tired, they may feel nauseous, they may be throwing up and all that. So these drugs that we'll give them, I mean, will help them to suppress all these major side effects. Meanwhile, don't forget that before we start the chemo, we'll give them the chemotherapy, we'll give them the medications to go home with. Then we'll give them immune boosters. I mean, we know that one of the side effects of chemotherapy is myelosuppression, blood level will go down, then certain parameters in the blood can go down, like the white cell count, the platelets, the PAC cell, the PCV. So we would have prepped those patients we would have been expecting that they may have neutropenia. I mean, if they have myelosuppression, we would have given them prophylaxis, GCSF, granulocyte colony stimulating factor, filgrastim. We give them after 24 hours after chemotherapy, because we envisage that this may come up. It is only if you go and receive chemotherapy at a quacks or at a quack center. If you go to a certified center, or you go and see radiation oncologists or oncologists, that this is what they do all the time, they will know what to do before the chemotherapy to reduce side effects, after your chemotherapy to reduce side effects, and they will know how to follow you up. If you come around with any symptom or say, doctor, I'm feeling this way, we'll have an idea. This is what the patient might be going through. Then we'll check blood counts every week to see the effect of the chemotherapy we have given. I mean, is this patient starting to experience myelosuppression? Is it that the blood volume has gone down, the PCV has gone down, or the has gone down, or the white cell count has gone down, or the neutrophil has gone down? Because neutropenia is an oncology emergency. I mean, we call after taking chemotherapy. So we support them with GCSF. We have to rehydrate the patient. They may feel tired. Some of them they may lose appetite. We give drugs that will boost their appetite. Apart from immune booster, we will give them drugs that will boost their appetite. We'll also give them imatinib that will help them form bloods and all that. So basically, if they go to centers, I mean, they won't really have experienced so much of the side effects that people are shouting about here and there.
All right, Dr.
Olatunji-Agunbiade. Because we know what to expect.
All right, your call to action briefly. We need to leave now. Let's have your call to action.
All right. The number one treatment is prevention of cancer is prevention. If you prevent it in the first place and you don't have it, I mean, don't forget I've mentioned that there are some non-modifiable that you don't have power over, but the ones that you have power over can change. If you do those things and reduce your risk, I mean, as individuals, we can encourage that. As health sectors, like health practitioners, we can do it. As government parastatals, we can do it. I mean, media houses, I mean, we keep making noise about these things every day till this information, I mean, sinks into people's heads and know that, hey, this thing is real. We have to do what is needful so that we don't have the disease. And if you have it, if you have it, you notice any of the signs and symptoms that we've mentioned, prompt presentation at the hospitals. I mean, go and see the specialists, let them start treatment on time. don't go into denial, don't stay at home. And I know it's not easy for money and all that. Government now is trying to look for how they can, they're trying to support patients with health insurance and all that. So we're still looking for means of including radiotherapy into this insurance scheme. I mean, although it's not easy, but majority are paying out of pocket. So we're praying, and we're praying that the government will also continue to do more. But the government alone cannot do it alone. The modifiable risk factors, government cannot do it for you. You have to do it by yourself. The ones that government should do. As healthcare workers, we will do our best to close the care gap. So you all have to help us as well.
All right, Dr. Olatunji-Agunbiade, thank you so much for your time once again. We really appreciate you.
Thank you for having me, America. Thank you so much. It's been a pleasure sharing this knowledge. Thank you so much. I really appreciate it.
Thank you. You're welcome. I have been speaking with Dr. Temitope Olatunji-Agunbiade, consultant, radiation and clinical oncologist with the Oncology Department, Lagos State University Teaching Hospital, Ikeja in Lagos. Here, she has been telling us how to detect breast cancer early enough. We now bring you trending health report from around the world. Please stay tuned. It is still Sound Health on Lagos Television. More to come in a moment. Well, this is where we say thank you on today's episode of Sound Health. It takes a lot of courage to be body aware, detect breast cancer early enough. Don't forget to touch, look, and check. For comments and inquiries, please send SMS to 0035826603 or follow us on social media at LTV Social, #SoundHealth. A sound health is a sound mind. Make healthy living your choice.